Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Batwer, the editor of GP Online. Coming up on the podcast today, myself and our deputy editor Nick Bostock will be looking in detail at the review of the NHS by Lord Ara Darzi, the government's response to the report and what happens next. We're also discussing another report Lord Darzi was involved with, the IPPR think tank's final report from its Commission on Health and Prosperity. We'll be looking at what that had to say and what it could all mean for general practice and the NHS. And we're talking about Health and Social Care Secretary Wes Streeting's war of words with the BMA over collective action. But our good news story this week is also very good news for the government, as junior doctors, who are now called resident doctors, voted to accept the new pay offer, which brings an end to 18 months of industrial action. That's all to come on this episode of Talking General Practice. So first up, one of the big news stories from the past fortnight was the publication of former Labour Health Minister Lord Ara Darzi's review into the NHS, which we're going to be looking at in detail today. Nick, as I mentioned there, Lord Darzi is a former health minister. He served under Gordon Brown and he's also a surgeon at Imperial College London. He actually sits in the House of Lords as an independent peer now. But what exactly was this review and what was he asked to look at?
The government asked Lord Darzi to carry out a rapid independent review of the NHS with a particular focus on access to healthcare, quality of care and the overall performance of the health service. And this review was announced just a week after the general election at the start of July, and it's been completed about 8 weeks later. So clearly a fair bit about the problems the NHS is facing is already well known. But the review effectively outlines publicly what the new government has inherited in terms of the state of the NHS, of the health service as it stands, and it provides a baseline that the government plans to build from. So the government's developing a 10-year plan for the NHS, and this review sets the scene for that plan in terms of problems that the plan needs to address, and Lord Darzi set out some recommendations as part of the review. Part of the focus of the review too was not just to highlight problems on a national basis, but also to look at health inequality and variation in demand, access and the quality and outcomes of NHS services.
There was a lot in that report, and we'll come on to a minute to talk about some of the wider findings. But firstly, what exactly did it have to say about general practice?
You mentioned earlier that Lord Darzi is an eminent hospital doctor, and I think that's been a cause for concern for GPs, often that the person asked to diagnose the problems facing the health service isn't someone with direct professional experience of general practice. But some of the overall findings from the review are very much in line with issues GPs often raise. So the need to move a greater share of NHS funding into primary care, issues around rising demand linked to an ageing and increasingly complex population, problems with the GP workforce shrinking and inequality in GP provision across the country and how that links to the way general practice is funded. One of the major themes Lord Darzi said the government's forthcoming 10-year plan would need to tackle is the need for GP services, along with mental health and other community services, to expand to cope with rising demand from growing numbers of patients with long-term conditions. And he said that NHS financial flows need to be hardwired to lock in that change irreversibly. The review made a point that GP leaders often raise, said that GP practices have the best financial discipline in the health service family because unlike hospital trusts, they can't run up large deficits in the belief that they'll be bailed out. But it pointed out that despite rising productivity, an expanding role and evident capacity constraints in primary care, the relative share of NHS funding that it receives has dropped significantly over the past decade or so. So in 2009, 24% of the NHS budget went to primary care, but by 2021, that had fallen to just 18%. And Lord Darzi said GP's frustration at being asked to deliver more work for a lesser share of NHS funding at a time when the hospital workforce has expanded massively and the GP workforce has shrunk was understandable. Lord Darzi said the UK has underinvested in community-based health services, including general practice. And he pointed out that the UK now has almost 16% fewer fully qualified GPs than other high-income countries relative to our population. There's a very clear message, there's a very clear challenge to the government here. General practice is cost efficient, but has been systematically underfunded, and that needs to change to set the NHS up to support an ageing population. So as well as setting a baseline for the government, there's a real marker here that GP leaders may be able to use to hold ministers' feet to the fire. GP leaders can hold this up and say, here's what your review said. Now we need to see the evidence that the government's following this advice and shifting more money into general practice and helping expand capacity in the way that's clearly needed. Another point to make here is that these points in the Darzi review absolutely underline the case for collective action GPs across England are taking at the moment. Collective action means things like GPs limiting daily patient contacts to a safe level. It means practices stopping providing services they aren't funded to deliver. And these are actions practices are having to take to protect themselves and their patients. Because as the Darzi review says, pressure and demand on general practice has risen, but funding and the GP workforce simply haven't kept pace with that.
Yeah, we're going to come on and talk a bit more about collective action in a bit, but the report itself made for some pretty grim reading, identifying a litany of problems across all areas of the NHS. Darzi himself said his findings about the state of the health service and the state of the nation's health had really shocked him, despite him having worked in the NHS for over 30 years. Although, to be honest, I thought a lot of what he had to say would have felt very, very familiar to people working in the NHS. Lord Darzi also pointed out that it had taken more than a decade for the NHS to fall into disrepair, as he put it, and that would take time to fix. He said it was unlikely that waiting lists could be cleared and other performance standards hit again within the term of one parliament. So that's going to be tricky for the government, isn't it? I mean, they'll need to show some decent progress on the NHS by the time of the next general election, but this report suggests things are certainly not going to be perfect or back to the NHS being at its highest performing level by then. So, what else did the report have to say? So firstly, Lord Darzi said the state of the nation's health was deteriorating. He highlighted a surge in people with multiple long-term conditions and a big rise in mental health issues, particularly among children and young people, and also pointed out that most of the social determinants of health have moved in the wrong direction over the past 15 years. And as you mentioned, Nick, that all of those things, coupled with an ageing population, has led to the NHS as a whole facing, huge levels of demand. At the same time, as I said, the NHS is in a pretty dire state. Waiting targets across all sectors are being missed. The report said it quoted figures suggesting A&E waits could be causing an additional 14,000 deaths a year. That figure was picked up quite widely in the media. Meanwhile, the UK has cancer mortality rates higher than other countries, and care for cardiovascular disease is also going in the wrong direction. Nick, you've mentioned about too much money being spent in hospitals and too little in the community, but the report also highlights that despite all of that, productivities in hospitals is now too low. There's been a massive growth in the number of staff working in hospitals, but the number of appointments, operations and procedures have not increased at the same rate. And the report blames that on the fact that patients no longer flow through hospitals as they should because of A, the terrible state of social care, and B, a lack of investment in general infrastructure. And that means hospital staff are spending loads of their time trying to solve process problems, such as trying to find a spare bed for a patient, which the report says, and I quote this, crushes their enjoyment of work and means they still have really heavy workloads despite the fact not as much work is being done.
Those are some of the problems that the NHS is facing. But what does the report say about why things have got as bad as they are?
It also looked at why we're in this mess and concluded that there were 4 key factors that led to this. So austerity, the pandemic, poor staff and patient engagement, and management structures and systems. So the first of those, NHS funding since 2010 has failed to keep pace with what it needed really to cope with a growing and ageing population. Meanwhile, this will be a familiar problem to everybody in the NHS. The health service has been starved of capital funding, those budgets often being used to plug gaps in day-to-day spending. Interestingly, Lord Darzi also identified a £37 billion shortfall in capital funding. He says that's the amount that should have been invested in the NHS during the 2010s if it had matched levels of capital investment in health systems in other similar countries. And that's a staggering figure. And the report says that that sum of money could have effectively rebuilt or refurbished every GP practice in England. And it really does reflect that the previous government really just has not invested in infrastructure we need in public services. Lack of capital investment also means we have less scanners per population than most other similar countries. And there's been too little investment in digital automation and digital technology, the report also said. And all of that lack of funding meant effectively the NHS was not very well equipped to deal with the pandemic when it happened. And consequently, we now have a bigger backlog than other similar countries. On top of that, patient satisfaction is falling, staff sickness levels are really high, and staff are increasingly frustrated and unhappy about working in a system that doesn't really function effectively. Lord Darzi also said that, the reorganisation of the NHS in 2012 under the coalition government, that came in for some pretty serious criticism in this report. That was the reform which saw the establishment of NHS England and clinical commissioning groups. And the report says that reform was absolutely disastrous. It basically cost a fortune, led to the loss of lots of experienced managers, and effectively broke the system for a decade. So all of that, pretty bad. But despite all of that, Nick, there were some actual positive conclusions in the end from Lord Darzi, weren't there? He didn't feel like the whole situation was beyond repair, did he?
There are a couple of positive notes in there, even if the overall diagnosis, as you've said, was pretty bleak. Lord Darzi said that although the NHS was in serious trouble, it could recover with the right support. He said the NHS was in critical condition, but that its vital signs were strong. And he picked out NHS staff as the beating heart of the health service. And he pointed out that there's an extraordinary wealth of clinical talent in the UK, which is admired worldwide. And he said too that even though there's a massive gap in capital investment in the health service, it has more resources than ever before. So there is a platform to build from in that respect. Another fundamental point was that Lord Darzi said nothing he'd found called into question the idea of a tax-funded health service free at the point of use based on need rather than ability to pay. And he pointed to evidence that alternative systems that charge patients or rely on insurance tend to be more expensive. And he concluded that ultimately the UK can't afford not to have the NHS. So solving the problems it faces is imperative.
Yeah, and so after the report was published, obviously we saw a response from the Prime Minister, Sir Keir Starmer. What did he have to say about it?
First of all, this is obviously a sign of the importance the government attaches to its plans around the NHS, that it was Keir Starmer rather than Wes Streeting delivering the government's response to the Darzi review. But maybe part of the reason for this approach is that the government's response is very much tied up with its wider, slightly depressing messaging about the state of the public finances that it inherited from the previous government and what that means for its ability to spend on improving public services such as the NHS. Keir Starmer's message on this was fairly stark. He said that for the NHS, it's now a case of reform or die after what he called a lost decade for the health service, as you mentioned, through the 2010s. The basis for this reform or die line, which he actually softened a bit later by saying there would be no more funding without reform, is that the health service is at a sort of crossroads and big decisions need to be taken about how to make it capable of dealing with the increased pressures it's facing. Keir Starmer framed this as a straight choice between reform on the one hand and raising taxes on the other, and he argued that working people can't afford to pay more, so it's reform or die. And it's worth noting here that surveys show there is a willingness among much of the general public to pay more to improve the health service. But this is how the Prime Minister says he sees the situation. He also said the NHS needed long-term reform and that it would be major surgery, not sticking plaster solutions that the government would look to implement. That this is what the government's working at pace to build into a forthcoming 10-year plan for the NHS. And that plan, the government says, will have the fingerprints of NHS staff and patients all over it. That was Keir Starmer's line. And that's really an attempt to differentiate this government's approach from the way it sees Andrew Lansley's 2012 reforms as having been implemented in a much more top-down way.
Lord Darzi himself in his report had some thoughts about what the long-term plan would need to cover. I mean, the report sets out what he says are important themes that had emerged during his investigation, which showed how to rebuild the NHS. We've talked about that shift of more funding for the community, more funding moving from hospitals to the community. And also there's a real emphasis in the report on this move to a neighbourhood NHS. So we've talked about this on the podcast before, this idea of neighbourhood health centres. We know this is something that Lord Darzi himself was keen on back when he was a health minister under Gordon Brown. I think you and I, Nick, both have written about Darzi centres back in the day. This is basically a revival of that sort of model. We also know that the new government planned to trial these. It was in the Labour manifesto. Wes Streeting talked about it before the election, and he confirmed that plan to set up trials of neighbourhood health centres in a piece he wrote for GP Online shortly after he became Health Secretary. In terms of other things Darzi said he would like to see in this NHS plan, he said re-engaging staff and re-empowering patients would be key. And you mentioned there, Nick, about patients and staff having their fingerprints all over the NHS plan. And that's something that I heard Wes Streeting say at an event I was at during the election, where he spoke about the long-term plan there. And he said he saw it as being something that would very much be developed in partnership with people working in the NHS and not something that would be imposed on them from above. He saw that as really being critical to any plan's success. So I think that's obviously a way you could start to re-engage staff there if they're involved in developing the plan and they feel they start to see some improvements from it fairly quickly. I think seeing improvements quite soon after it comes out will be quite key to all of this. The other thing he sort of said was about making the NHS structure clearer so everyone knows who is responsible for what. And finally, very unsurprisingly, no one will be surprised to hear this, he also said that there needed to be what he called a tilt towards technology to improve productivity, and that would also involve making use of AI and developments in life sciences to create new treatments that would improve health. So that's what Darzi said a plan for the NHS needed to focus on. But do we know anything exactly about what will be in the plan? I mentioned the neighbourhood health centres. We know the government's committed to that. But what else did Keir Starmer have to say about what the long-term plan could cover, Nick?
The Prime Minister said the government's plan to fix the health service will focus on 3 key reforms. So these are building off of some of the themes that Lord Darzi's report covered. But he talked about moving the health service from analogue to digital, moving more care from hospitals to communities, and then a much bolder approach to shifting from a sickness service to one focused on prevention. And on moving from analogue to digital, he said the government wants to use technology to empower patients, give them much more control over their healthcare. And he talked about the potential for the NHS app to become a digital front door to the NHS, and so take on a much more central place in patients' interaction with the health service than it currently has. On moving care from hospitals to communities, he acknowledged that successive governments have promised that, but that the opposite has happened, with a larger share of NHS funding going to hospitals now than in the past. And he said the government's 10-year plan has to be the moment we change this. And he tied that to changes the government wants to make to general practice, to turn the NHS into a neighbourhood health service with more tests, scans and healthcare offered out of hospital on high streets. And he mentioned plans to improve GP access and bring back the family doctor. On prevention, he talked about expanding health checks and improving mental health services and dentistry, particularly for children. But I think on all these points, there are a lot of questions the 10-year plan is going to have to answer. So what impacts will the digital revolution have on the confidentiality of patient data, for example, and on the relationship that GPs have with their patients as the data controller for information held in those patient records? And what role does the government see for AI in all of this? The RCGP only recently felt the need to spell out that AI won't ever replace fully qualified GPs, after a report from an organisation that has quite close ties to the current government suggested an NHS digital revolution could lead to AI doctors. And when it comes to moving care into community settings, will that come with money or lead to unfunded work being dumped on practices, and GPs being expected to manage more tests and checks that used to happen in hospitals, as has been the case with an approach like advice and guidance? How will funding work for the idea of a neighbourhood NHS? Will GPs hold the funding and have the ability to work out how to use it? Or will it mean core GP services being underfunded while investment goes to new areas of work, as has been the case with funding for primary care networks? If prevention means more GPs, will the government provide long-term funding to help recruit and retain GPs trained in the UK, many of whom are currently leaving to work in other countries, retiring early or reducing their working hours, or unemployed? because practices can't afford to recruit them.
Yeah, I mean, there's a lot of questions about what's going to be in this plan, aren't there, really? I mean, general reports seem to suggest that it will be out in spring of next year. The RCGP chair, Professor Camilla Hawthorne, said she really wanted to see how the plan will actually deliver on more resources for care in the community and for general practice. But all those questions that you mentioned there, Nick, do you think this long-term plan will mean more funding for general practice?
It seems like it should do. But as I mentioned just now, the government's suggesting there's not going to be a step change in funding overall for the NHS in the way that there was in the early 2000s. The Darzi review clearly says the balance between funding for primary care and hospitals is wrong at the moment, or has moved in the wrong direction. But how easy is it going to be to strip money out of hospitals and move services into the community if that's what the government decides it needs to do as part of shifting services into the community? When we talk about more funding for general practice, the last government's long-term NHS plan also talked about more funding for general practice, but largely, and this is a point we've just touched on, that wasn't directed into core general practice. It didn't increase the funding practices received through the GP contract. So how will any new or diverted money from reforms under this government be delivered to general practice? Will it affect, and if so, how, what practices actually have in their coffers? And that sort of detail basically is miles off at this stage.
That report really sets out such a stark picture of some of the problems facing the NHS, and we talk all the time about the problems facing general practice. It just seems almost like it would be impossible to fix this without more funding. I mean, the government's very keen to try and argue or point out that, you know, it's not going to give more money unless there's some changes, and that's all well and good. But I think even Ed Balls on his podcast sort of said the only reason that Labour managed to achieve the improvements they did in the NHS in the 2000s was because they piled extra resources in there. And I know we're in a very different financial situation. The country's in a very different financial situation now than it was then. But it really is hard to see how things are going to turn around unless there is more money coming into the health service from somewhere. And that means more money for the day-to-day business of running the health service. But obviously, clearly, this report shows it means an absolutely huge amount of money needs to go in for capital investment on equipment, technology, and obviously to repair crumbling buildings, not least the many GP practices that are really struggling with space at the moment.
Two of the things that you pointed out that Lord Darzi had identified as the major causes of the problems the NHS is facing were long-term underfunding and then the impact of a major programme of reform. It's hard not to point out or consider there's a little bit of a disconnect when the answer to long-term underfunding and a major programme of reform seems to be no new funding and another programme of reform. You could be forgiven for being a little bit sceptical about the chances of success of a programme built on that platform.
It's a really good point. I suppose we've got to really wait and see what is actually in the long-term plan and what kind of changes the government wants the NHS to make in order to deliver these improvements. So anyway, lots to wait for them. But as I mentioned at the start, this wasn't the only report that Lord Darzi's been involved with over the past fortnight, is it? This week, the IPPR think tank published its final report from its Commission on Health and Prosperity, which was a 3-year inquiry chaired by Lord Darzi and former England Chief Medical Officer, Professor Dame Sally Davies. So this inquiry was looking at the interaction between health and the economy and concluded that better health is necessary to improve the country's economic performance. Nick, what exactly did this report have to say?
So maybe unsurprisingly, given Lord Darzi's fingerprints are on this report too, some of its findings are similar to what came out of his rapid review of the health service we've just been talking about. The report from the Commission called for a major overhaul to transform the NHS from a reactive, sickness-orientated 20th century healthcare system into a proactive 21st century health creation system that works alongside a sickness service. So that part very much fits with one of Keir Starmer's stated aims on the back of the Darzi review, which is to move towards a more prevention-focused NHS. And the Commission also talks about Britain's population getting sicker, which is another theme from the Darzi review. Numbers of people with long-term conditions and people who are complex patients for GPs to deal with because they have multiple long-term conditions are rising rapidly. And it talks about part of that being down to ageing, but it points out that there's also been a huge rise in numbers of people of working age who are living with long-term conditions, and a sharp rise in the number of people unable to work because of health problems. So a big focus of the report is on recommendations around a health-focused industrial strategy, restoration of critical community infrastructure, higher standards for health at work, and integration between health and employment support services. And this is part of a plan to add 10 years to healthy life expectancy by 2055 and to halve regional health inequalities.
That's a really good ambition to have, isn't it? But what did it actually have to say about general practice? Because it did have some sort of vaguely controversial things to say about general practice, didn't it?
So alongside the wider messages around the NHS and the interaction between the NHS and the economy, the report is actually very critical of the current model of primary care. And in particular, it singles out the independent contractor model for criticism. So the independent contractor model is also known as the GP partnership model. It's the current traditional model of general practice. But some of the content of this report, which has been welcomed by Wes Streeting as something he's going to study closely as the government shapes its plans for NHS reform, might sound fairly alarming for general practice. The Commission talked about needing to reorient the NHS towards primary and community services. So that's that theme about moving care out of hospitals again. And it says this is necessary to tackle inequality, to move towards prevention and tackle rising demand from patients with complex needs. But it said that the current model of primary and community care isn't organised in a way that can deliver that shift. It said the independent contractor model, the fact that GPs are contractors rather than directly run NHS providers like hospitals, for example, is the reason why secondary care services are often prioritised for new powers or resources when the NHS is making decisions about how to allocate those. And it says the health service is more likely to prioritise parts of the health system. It has more levers to direct. The report says the independent contractor model encourages small providers that can't deliver at scale, that it can lead to gaps between hospitals and primary care services. And it talks about the way it shifts risk onto partners. And that's something that's sort of putting partners off, or GPs off becoming partners. It's worth pointing out here that this is the same independent contractor model that Lord Darzi's other report highlighted as being efficient because it can't bust its budget and expect a bailout in the way that other parts of the health service do. So make of that what you will. The Commission also proposes a neighbourhood NHS, which echoes the language Wes Streeting's used about bringing more services together under one roof in primary care. But it also says this could work on something it's described as a hub and spoke basis, with groups of practices working around a hub, the hub being the place where at-scale services population health work is delivered, while the spokes hold practice lists and concentrate on continuity of care. So it's effectively, it sounds a bit like a reimagining of PCNs in some ways, which the report says GPs have often not had the capacity to make advances on delivering care at scale through.
Yeah, so taking all of this together, this IPPR report that came out this week, the Darzi review that came out last week, and then the long-term plan, which we know is coming next spring, hopefully. What do we think all of this is going to mean for general practice in the next few years under this government?
It's difficult to be sure about exactly how this will pan out because, as we've touched on, some of the reform ideas set out in these reports, things like moving more care out of hospitals or a big focus on prevention, those are things governments have promised before and not been able to deliver. In terms of the idea of a neighbourhood NHS, that looks likely to be something that moves forward in some form because the new Health and Social Care Secretary said straight after the general election that the government would trial new neighbourhood health centres with more services under one roof around general practice. And the Darzi report used very similar language. And in fact, the pilots NHS England is working on around Claire Fuller's vision for the health service, which talked about turning PCNs into integrated neighbourhood teams, also sound pretty similar. But exactly what this means for GPs is still quite hard to say. Will it be something that comes as part of a big overhaul of the GP contract, which is something that BMA GP committee wants to embark on? Or will the neighbourhood NHS take shape around GP services rather than with or through them and sort of separate from the GP contract? In terms of the criticism of the independent contractor model, we know that Wes Streeting and Keir Starmer have both criticised that in the past. Wes Streeting called it murky. Keir Starmer said last year that in many cases it was coming to the end of its life. And Wes Streeting has said since that he thinks the GP partnership model should remain, but that there ought to be alternatives because not all GPs want to be partners anymore. You could certainly argue that more would want to be partners if the funding hadn't been eroded so much over the past decade and a half. But clearly there is an appetite for alternatives at the very least, if not an outright scrapping of the current model. And beyond that, some of what happens might depend on negotiations, how the relationship between the BMA and the government evolves, and we're about to come on to that a bit more.
So Health and Social Care Secretary Wes Streeting, who we've mentioned a few times today on the podcast, was also doing the media rounds last week as Lord Darzi's review came out. And he caused a bit of a stir when he had a bit of a go at the BMA on the Today programme, didn't he, Nick? What did he have to say? Why was he being so critical of the BMA?
So Wes Streeting criticised the BMA GP committee for what he called sabre rattling and the unnecessary threat of collective action. And he contrasted that with how the government had been able to sit down with junior doctors, now known as resident doctors, as you mentioned, and come to an agreement over pay. So GPs have seen pay increase this year. There's a 7.4% increase in global sum funding for 2024-25 compared with the previous financial year. But the profession is still taking collective action. GPs are still taking that action because as things stand, they can't afford to recruit, which is why many GPs are out of work. As Lord Darzi and others have said, workload has risen rapidly, while funding and numbers of qualified GPs have dropped. So collective action is about, as the BMA GP committee puts it, GPs controlling the speed of their hamster wheel. And they're doing this within the terms of their contract, not seeing more patients than is safe, stopping providing work they aren't funded to provide. So it's very different from industrial action or strikes. This is simply about GPs taking actions that the BMA has recommended for many years to control their workload within the bounds of their contract. But Wes Streeting feels taking this action constitutes an unnecessary threat and that it could put patients at risk. So he wants GPs to back down.
Dr. Katie Bramwell-Stainer, the BMA England GP Committee Chair, was on the Today programme the following day and she had quite a robust response. What did she have to say?
Dr. Bramwell-Stainer said the Health and Social Care Secretary's comments were disappointing and that it was not sabre-rattling to point out that general practice has lost 2,000 practices over the past 15 years and that, as she put it, thousands of GPs have been hemorrhaged from the NHS. She said that 1 in 4 GPs knows another GP who's taken their own life. So that's the scale of the pressure the profession is under. And she said that general practice can't wait for long-term plans or future spending reviews. It has to take action now to control its own workload in this way, to keep patients safe and to keep GPs safe. So there's a bit of a gulf in terms of how the government and the BMA are characterising this.
When Wes Streeting talks about sabre rattling, this is something very much that lots of GPs are on board with. It's not just the BMA that's backing collective action, it's actually practices themselves that are doing this.
Yeah, I think to go back to that point, there was a suggestion in Wes Streeting's remarks that this was about, that there was a bit of a difference of opinion between the BMA GP leadership, who were sabre rattling, and perhaps grassroots GPs who weren't quite in the same place. That was the suggestion he made. As you say, the BMA has said that more than 4 in 5 GP practices across England, so that's potentially 5,000 practices or more, are already taking part in collective action. GPs are very much signed up to taking these steps. And as we know, GPs voted strongly in favour of taking these measures in a BMA ballot, and many of them are clearly pressing ahead with exactly that.
You mentioned earlier there has been some pretty positive news for the government though, because obviously the junior doctors, or residence doctors as they're now called, they voted to accept the latest pay offer, and that's obviously a really positive step, and Wes Streeting and Keir Starmer will obviously be really relieved about that. They'll have something positive and concrete to point towards as an example of something they've achieved in their first 100 days in office. We'll come on to talk a little bit more about the junior doctors deal in a minute. Now, earlier this year, consultants also agreed a deal which saw a big overhaul of pay structures, and those doctors got an additional uplift last year. SAS doctors also agreed an improved pay deal earlier this year. We know GP income is falling. Most partners' pay went down last year. GP partners are unlikely to get that 6% that was recommended by the DDRB. We've talked about that on the podcast before. This new government, it may not like the fact that GPs are taking collective action, but when you consider it in the framework of all the other branches of medicine, it's not really surprising we've reached this point, is it? I mean, how do you think all of this could impact on the government's relationship with GPs going forward? Everyone seems to have started off on quite a positive footing since the election. They're trying to talk positively about everything. But do you think collective action is going to affect that relationship?
So Katie Bramwell-Stainer has said that the BMA GP committee remains committed to working with Wes Streeting and the government. And she said that she's ready to talk more with the government. And hopefully the government shares that sentiment and will get back around the table with GP leaders to try and find some more common ground. But I think it's worth mentioning here too that collective action is going to be a pressure point over winter. NHS England wrote to ICBs this week about needing to get GPs to work on actively avoiding hospital referrals for patients with long-term conditions as part of the NHS winter plan. And of course, GPs will do what they can to keep patients out of hospital, not just in winter, but all of the time. But one of the measures GP practice could take as part of collective action is refusing to engage with advice and guidance. Advice and guidance is something NHS England sees as a huge part of its plans to keep patients out of hospital and reduce outpatient appointments. But as GPs have pointed out, it involves moving a whole load of work out of hospitals into general practice. And as things stand, that's been done without funding. So stopping advice and guidance is something GPs can do without breaching their contracts. They aren't funded or contracted to use advice and guidance. But while pulling out of it's easy to justify, that doesn't mean it won't have an impact on the relationship with NHS England and ultimately the government. We come back to that point from a minute ago. We talked about the government saying that with its 10-year plan of reform, it wants the fingerprints of NHS staff and patients to be all over these plans. But as things stand, there are certainly some cracks in the relationship between the BMA England GP committee and Wes Streeting and the government. The question is, I suppose, what impact, how that relationship is working out, have on GPs' ability to influence the shape of the government's 10-year plan, and what impact might it have on what the government ultimately decides to map out for the future for general practice.
Before we go, we've just got time for our regular good news slot, which this week is about a story we've already mentioned, junior doctors accepting the latest pay deal. The government has also agreed with the BMA that from now on, junior doctors will be referred to as resident doctors. The BMA says that this title better reflects their level of experience and expertise, and it follows a move by GP registrars away from calling themselves GP trainees earlier this year. So in terms of the pay deal, more than 45,800 resident doctors in England took part in a referendum, with 66% voting in favour of accepting the offer and 34% voting against. Turnout was 69%. As I said earlier, the deal means that on average, junior doctors will see a pay uplift of 22.3% across 23-24 and 24-25 combined, although the BMA warned that despite the uplift, pay remains 20.8% behind in real terms compared to 2008 after more than a decade of erosion. There's also going to be some changes to the rotational system of how placements are allocated, which will aim to reduce some of the bureaucratic issues involved with rotating, which I think everyone will welcome. The BMA has also said that they know this is a first step, and that there was a bit of a warning to the government that if the independent pay review process isn't seen to be delivering on eventually restoring levels of pay for resident doctors, then there would be consequences for the government. So resident doctors leaders from the BMA said that the campaign for pay restoration was not over, but that all resident doctors should be proud of how far they've got. But this obviously is really good news, brings to an end 18 months of strike action, particularly given we're heading into winter again and waiting lists are still absolutely massive. I'm sure hospital managers in particular will be breathing a big sigh of relief. Well, that's it for this week. Thanks so much for listening, and thanks to Nick. I'll be back next week, so please do join me then. In the meantime, don't forget you can keep up to date with all the latest news affecting general practice and access many other resources on our website at GPonline.com.